apologize, I had to step away for a little bit. So I'm going to talk about sort of the nuts and bolts of initiating an SSO2 program. Here are my disclosures. So this is what I sort of regard as the blueprint for setting up an SSO2 program. This is what we sort of followed at my institution at the University of Chicago. I won't bore you with sort of the data. You've already heard that. There's a lot more to discuss, but really just kind of drill down on understanding the value proposition of SSO2, some of the capital equipment and disposables and how you navigate that, and then team training and actually just getting the case done. What are the practical issues associated with getting that case done? But I think it starts with sort of an objective assessment of what actually improves outcomes, morbidity and mortality in STEMI. Everybody has their sort of favorite balloon, their favorite stent, their favorite whatever, but if you really drill down on what actually improves outcomes, it's primary PCI versus fibrinolytics, it's potent P2Y12 inhibition, door to balloon less than 90, with the recognition as we get better and better with door to balloon, we're not seeing the commensurate benefits in terms of outcomes. So national D2B is like 62, 63 minutes. We're not worlds better than we were when we were 80 minutes. Early revascularization versus medical stabilization in AMI shock, radial versus femoral, complete revasc, and then GDMT. So the value proposition is simple, as has already been highlighted by the previous speakers. 1 in 5 STEMI patients at least go on to develop heart failure. SSO2 therapy has been shown to restore microvascular flow and reduce infarct size to a substantial degree, and also lower heart failure and mortality in treated patients versus controls. And the mechanism of action can be sort of simplified into a couple of concepts. The 3 potential mechanisms. Most prosaic explanation is the diffusive effect of superoxygenated plasma, independent of RBC traffic, reduced endothelial cell edema, and mitigation of free radical injury. And so the objective reasons, just to kind of bring it back from where Dr. Estep started, the objective reasons why SSO2 could potentially offer significant incremental therapeutic values that STEMIs like cardiogenic shock are not going away anytime soon. There's been a shift in STEMI and non-STEMIs, but there's still plenty of them to be treated. Anterior STEMIs, as we all recognize, are uniquely dangerous, and the most impactful aspects of evidence-based therapies are finally starting to reach their individual therapeutic ceilings, and so there's not a whole lot more to squeeze out of the things that we're already doing. And on the side of the therapy itself, implementing very complicated therapies becomes very tough. So the recognition that SSO2 is cheap, simple, and effective is important, and it fulfills a therapeutic niche that's largely under-recognized and at the moment totally unaddressed. The magnitude of reduction that we're proposing here actually, falls in line with many other, therapies that are in the pipeline, including door to unload if that pans out, and many other strategies that we're looking at. So on to the equipment. So the capital purchase is this. If you purchase it or get it through a bundle with the number of disposables that you order, it's the console. The console takes an oxygen tank. Any standard oxygen tank goes in the back with a minimum of 800 PSI. These are the disposables. These are all the SKU numbers, and we keep a decent number of the purpose-built 7 French Merit sheets, as well as the cartridges and various shapes and sizes for delivering the therapy. Setup and use is dead simple. The mobile console is primed, the cartridge is inserted, and then make wet-to-wet connections, as I'll show you here in just a second. I don't want to geek out on the science of it, but the science of it is really interesting, how you actually supersaturate saline, basically create aqueous O2, and don't have bubble nucleation as it's actually being dripped in is fascinating. And so there's a lot of very interesting technology that yielded this complete system. For most of our cases, we've done all of our cases. We've done femoral access with ultrasound-guided puncture and a 7 French sheath at the end. This is the sheath. As you can see, the sidearm is substantially larger than the sidearm of a standard introducer sheath, and so that amount of flow requires a sidearm that large. If you are using a radial approach, a minimum of a 5 French radial sheath for the outflow, for the return, as well as for drawing off the arterial blood in a 5 French femoral sheath is what's necessary. And the 2 configurations are shown here. I'm happy to share my slides with anyone who wants to see them. Prepping the patient, very simple. Essentially, attach the draw tubing to the sidearm of the 7 French sheath. Make sure that you've got this 4-way stopcock for ACT draws without interrupting therapy. And the port is pointed down, and then make a wet-to-wet connection between the return tubing and the 5 French catheter that's positioned in the left main. If you forget, or it's been a while between cases, if you scan the QR code on the machine, it pulls up the video that you see here, and in about 3 minutes, you can refresh your memory as to how to set this up. So setup for this system could not be any easier. And then I think, to get into some of the questions that I think were starting to come at Dr. St. John, how do you actually sort of get your staff in the mindset of, doing this efficiently? Start prepping the minute you cross with a wire and you're up with a balloon. The minute your clock is stopped is when you should be prepping this machine and just letting everyone know what's going to happen, so that there's a seamless transition to therapy. So, during a radial primary PCI, just for fun, we kind of scribbled down, because there was disagreement as to how long a radial versus femoral case takes. So we scribbled down on the bloody drape exactly when everything was happening. And you could see that the entire case from start to finish, from lidocaine to final images, was about 31 minutes. But it does leave about 15 minutes from the time of balloon inflation to case completion, IVUS optimization, leaves about 15 minutes to get everything set and ready to go. And then, of course, when therapy is completed, it'll let you know that it's time to end the procedure, disconnect all the equipment, and so forth. A question that frequently comes up is, how can you best utilize your 60 minutes post-PCI? It's kind of a drag to stand there at 2 in the morning for another 60 minutes. But the reality is that it's not like the bed is ready, that everyone's, ready to receive that patient in the ICU, at least not in our center. There is definitely some additional work that needs to be done. So generally what we will do is we'll break away the minute SSO2 starts happening, and team members will go take care of other issues, so that in the end, the incremental time expended on this is not the full 60 minutes. So speak to family, finish orders, case dictation, review the CTs for the 3 PERTs that you received while you were whiling away your time in a STEMI, drink coffee. But very importantly, make sure that the catheter remains positioned, and you check ACTs every 10 to 15 minutes and keep that ACT above 250 seconds. And so the last thing I'll say, if all of the prior talks and the science and the outcomes and so forth haven't been persuasive enough, the last thing I'll say is that we willingly spend time on improvements in post-PCI outcomes every single day. If you're doing it right, you're using intravascular imaging, physiologic testing for intermediate lesions, invasive hemodynamics and PA catheters, and cardiogenic shock. Lesion prep, sometimes many minutes to hours of lesion prep and imaging in complex and calcific CAD, CTO recanalization, and MCS and unloading. These are all things that we willingly accept. I would submit that SSO2 sort of falls in that same bucket of things that we should be thinking about for anterior STEMI. Thank you so much.
Thanks, Andy. And we've run a little bit over, just a minute or two, so maybe if there's any questions or comments from the audience or from the panel about this therapy, it would be great to hear. Anything in closing? No further comments? I think we heard, we heard about the rationale for this, the need for addressing microvascular obstruction. We've heard the results of clinical trials. We've seen the results of real-world experience in consistent improvements in left ventricular ejection fraction. And we've heard finally about, starting a program. You have a question, comment?
Thanks a lot. Thanks a lot for all of your presentations. Definitely exciting technology, and something that I feel like a lot of centers will benefit from. One of the obstacles that hasn't been addressed is how do you push this through your value analysis committee? So cost is a big issue in preliminary discussions that we've had internally. And I can only surmise that a lot of other institutions would also run into, from a hospital administration standpoint, as well as even amongst community members, how did you guys push it across? Your hospital administration would have a lot of cost concerns about the therapy, and how how you navigated that.
Well, I'll start. I mean, I think we have been lucky in the Baptist system that we have a very supportive administrative leadership structure. So I think once it was clear that the physician's office was a valuable thing to have, and that it helped patients, I think the leadership in our center was really on board. The Zoll team also provides a lot of support in terms of making sure that we're billing and coding optimally. So it really has not been a cost-losing type of development once we've gotten up and running. Is it in your experiences?
I was just going to comment that the team for Therax is really helpful and has some creative solutions, I think, for having some of those discussions. I know, having gone through it now at 2 institutions, I think every institution is a little different, but they do have some different ways of sort of presenting packages, financial packages, that I think administrators actually appreciate having options.
I would echo what Marcus and Nadia said. There's RVU and reimbursement associated with this. So the worst case scenario, you're helping patients and remaining cost neutral. That's the worst case scenario. Typically, you end up, profitable. But I think it starts with sort of a frank discussion of what we're actually trying to accomplish here. And there are many things that we use that we just, IVUS is very poorly reimbursed. IVUS for, transplant, allograft vasculopathy, which is part and parcel of, surveillance in our institution, is very poorly reimbursed. So there are many things that we do, and, our value analysis team is very understanding about that. And it says, look, if you think this is the right thing to do, so long as we're not, burning through cash to do it, it's fine. It was surprisingly not that hard to get this approved.